We're going to discuss evidence-based assessment.
With evidence-based assessment, we're going to use the data that we have collected from peer-reviewed journals and from scientific research that forms the basis of our critical thinking skills in nursing care. And one of the methods that we use most frequently is the nursing process. That is assessment, diagnosis, planning, implementation, and evaluation. So we're going to use assessment and collect our subjective and objective data together. Now, subjective data is what the patient experiences and reports to us how they feel, the symptoms the information that they give us. Objective data is what the nurse collects during an assessment. We can make observations about patients' behaviors. That would also be objective. Or we can look in the chart. We can gather labs. We can gather vital signs. That's objective data. Whenever we look at subjective and objective data, all of that together can be cues for us. Cues are things that we recognize that is either significant or insignificant depending on an issue. We then take that data and we form a nursing diagnosis. We analyze those cues to see what's going on. We try to make assumptions based off of what information we have gathered already and based on our knowledge base that we have as nurses. Then we decide that we're going to plan out what we're going to do. What should we do first? What solutions can we make based off of what we think is wrong with this patient? What do we need to do after we analyze those cues? And then we're going to implement those actions. We're going to take action. We're going to do what needs to be done first, and then the rest follows after that. Evaluation, we're going to come back and see if what we did worked. So together with the patient's record and labs forms the patient's database. The database is what is inside the patient's chart, their records, their labs, everything we put into that electronic medical record or paper record, that's the database. So all the information we have about the patient is the database. We use that database, and based off of what the patient appears and looks like, their assessment findings, then we make clinical judgments or diagnosis based off of that. All of the things that we do should be organized, factual, and complete assessment data is vital. We don't want to leave anything out.
Evidence-based assessment is using our resources from journal articles, research studies, medical experts that have all basically the people who have created our textbooks, the people who create the algorithms for emergency medicine and disease process management. We use that is the evidence-based assessment things that we draw on in order to make appropriate. There is an enormous amount of clinical evidence that validates the use of particular assessment techniques for nurses. For example, measuring a blood pressure screening for hypertension and early intervention decreases the risk of heart attack and stroke. We know that. We know that high blood pressure can lead to heart disease and leads to heart attacks and strokes. So an evidence-based assessment would be screening for high blood pressure. We monitor blood sugar levels and hemoglobin A1C for management of type 1 diabetes. And the list goes on of things that we screen for and things that we assess because we know that those things lead to health disease. Diagnostic reasoning is the process of analyzing health data and drawing conclusions to identify a diagnosis. Beginning examiners may be able to effectively collect data given if they've had adequate practice, but then they may treat all data the same. But expert examiners are able to rapidly collect data and determine which data is most significant on the basis of previous experience. By developing a consistent approach for collecting and analyzing data, nurses are able to make more accurate diagnoses. So we cluster or group together assessment data that appears like they associate together. A cue is a piece of information, a sign or a symptom, or a piece of lab work or imaging data that we would use. You're going to hear the word cues very frequently. An example of a cue is like an elevated heart rate, blood pressure, or increased respirations, and we can say that maybe they're associated with anxiety or maybe something's going on, but those are something that's elevated is abnormal, and that would be a cue for us to pay attention to that piece of information. Now, when you first encounter a patient and you have an incomplete data set, you will use abductive reasoning to produce the initial diagnosis. With abductive reasoning, it's thinking to determine the best explanation with the information that you have right now. In deductive reasoning, you will apply pathophysiology and things of that nature and pathology to help you decide what's going on. And in inductive reasoning, you will use your signs and symptoms as a guide. So you use all of this together in drawing your previous knowledge to effectively care for patients. Now, once you have some data, you may need to validate the data that you have. You want to make sure it's accurate. As you validate your information, you also look for gaps in data collection. Maybe you're missing a piece of information. Maybe you're missing the oxygen saturation. You're missing something that you need to help you decide what's going on. If if you have less experience, like analyzing breath sounds or heart murmurs, you may ask an expert to listen.
For example, we have Mr. John Smith case study. He's a 75-year-old that arrived in the emergency department via ambulance from a rehab hospital. Now, when we look at his information here, his database here, we're looking at the database, and he has a past medical history of high blood pressure, a left-sided stroke, impaired glucose tolerance, hyperlipidemia, gout, and obesity. So we see right here already that he's had quite an extensive medical history. We see that he's a smoker. He's quite a heavy smoker, and he has quite a few drinks, more than the recommended daily limit. He presents with chest pain and worsening cough with a sputum production. He's febrile and he's tachycardic. Tachypnic, so he's breathing fast. His chest x-ray shows pleural effusions, that's water within the lung cavity, fluid in the lung cavity. And then he also has consolidation of both lower lobes, that's usually suggestive of some type of pneumonia. And he has labs that are pending. So as the nurse, we're looking at this database and we're using those methods of clinical reasoning and the nursing process to formulate a suggestive cause of this patient's symptoms, and drawing on past pathophysiology knowledge that in health promotion and prevention knowledge, we know that smoking heavily can cause lung damage, and more specifically, has a risk for COPD, chronic obstructive pulmonary disease, and he also has quite a history of heart related things. So we can say, well, his chest pain could be related to a cardiac event, or maybe with the cough and sputum production, that's creating a sore chest from coughing so hard, and that could be the cause of chest pain. Or maybe he has developed COPD or bronchitis, because if you smoke cigarettes a lot, it creates lung damage and you have more at risk to having frequent bronchitis, so maybe that is what's going on. So we use everything we have that shows just a clinical reasoning.
The nursing process is a 5-step process that includes assessment, diagnosis, planning, implementation, and evaluation. During the assessment phase, you gather the data from the medical record and the patient and complete an assessment. As you move to the diagnosis phase, clinical findings are interpreted and clinical judgment is used to determine a diagnosis. And on the basis of the diagnosis, then you will formulate your goals and outcomes in collaboration with the patient as you complete the planning stage. You're going to plan on what you're going to do about the problem. Once you're done planning, then you implement the plan. So you're going to take action, you're going to apply oxygen, etc. And then when you're finished implementing, you evaluate the results. Did it work? Based on the evaluation, you may need to reassess or change the original plan. Nurses go back and forth throughout the nursing process in order to take care of their patients effectively. Now, pause the video and read through question 1 to see what you would think you would do if you had this hunch that the patient's elevated blood pressure was due to a pain level, even though they just received a blood pressure medication and pain medication 45 minutes ago. What would you consider in regards to this hunch? You can pause the video to review the correct and incorrect answers. Hopefully, you chose answer B. Then we should trust our hunch. However, having another member of the team to substantiate, to validate our what we decide was wrong, it would provide additional reinforcement for the hunch. Priority problems level is something that nurses do every day, all the time. We're always prioritizing patient care, and you have to learn how to prioritize patient care as well. It uses an interdisciplinary approach to improve outcomes for complex care or problems. So, a first level priority problem are those that are emergent, life threatening, immediate, like establishing an airway or supporting breathing. Those are your ABCs. If you don't have an airway, you can't breathe. If you can't breathe, you can't circulate. So, those are the things where I like to think about who will die first if I don't tend to this problem. Who's going to die first? Second level priorities are not as urgent as first level, but they do require prompt intervention to prevent further deterioration, like a mental status change, acute pain, acute urinary elimination problems, abnormal lab values, risk of infection, risk to safety or security. Those are second level priorities that need attention, but they're not life threatening in the moment. Third level problems are those that are still important to the patient's health, but we can wait on it. It can be attended. It can be attended after their first and second level priorities are taken care of. Interventions to these problems are usually long term, and the response to treatment is expected to take a lot more time. These problems require collaborative effort between the patient and healthcare professionals. So I look at something like maybe the patient's been constipated for 5 days. Okay, well, that's going to take some time to alleviate that issue. It's not urgent, they won't die from it. So I can put that on a third level priority.
So, with the explanation of what is evidence based assessment, what is evidence based practice, it's a systematic approach to practice that uses research evidence, clinical expertise, clinician knowledge, and the patient's preference and values that make decisions about care and treatment. And every examiner needs to follow the evidence-based assessment strategies. So we use all of this together, and then we also look for gaps in the literature, and we foster a culture of evidence-based practice. All nurses want to be able to use all the resources that we have to make the best choices for our patient.
There's different types of databases that nurses collect in their chart. So the first kind is the complete total health database. This is your full health database, the full health history, full physical exam, everything there is to know about the patient is in this full, complete, total health history. These are places like primary care would get these. Home health visits for the initial visit, admission assessments. This is your total health. The next one is a focus or problem center database. Here you collect the mini database, mainly about one particular problem, one body system. This is what you'll see in a hospital setting, maybe long term care, depending on what's going on. a hospitalized patient who needs a specific problem taken care of. That's what a focus thing is going to be about. A follow up database is the status of any identified problems that need to be evaluated at a regular interval. So, has anything changed in 3 months? Or maybe it's an hourly visit, or I mean, an hourly assessment. These type of databases are short term and they can be for chronic health problems, but they need frequent follow ups to manage that disease process. And of course, your emergency database is an urgent, rapid collection of crucial information for life saving measures. Like, I really just need to know, like, if you came into the emergency department with a substance abuse overdose, I'm going to want to know, when did you take it? How much did you take? I'm going to establish an airway database. I'm going to do those focus assessments that I need to do, and then I'm going to get important information like, do you have high blood pressure? Do you take a blood thinner? Do you have renal disease? Do you have diabetes? I need to know these major health problems with you so I can take care of you.
When providing a comprehensive health care, we're going to use a holistic model. A holistic model of health is thinking about the patient's mind, body, and spirit, emotional well being, social well being. It is looking at the whole picture for a holistic model of care. Nurses want to give holistic models of care, so we take care of all populations. We also think about social detriments of health, and that is referring to the environmental things that affects patients' health, whether or not they have access to care, if they have health literacy issues, and etc. Other factors that influence well-being, whether it's self-harm practices or alcoholism, smoking, things that affect their overall well-being as well. With the social detriments and given holistic care, we also consider their environment, their access, community and education, access to programs and other things. Maybe they don't have access to a health department, and their economic stability, so their poverty level. And we also think about any barriers that patients might have to health care, and we as nurses we try to alleviate those barriers. Now, genetics does play a really big role in patients' health because some things are unavoidable with genetics and what patients are at risk for, or what they inherit from their parents and grandparents as far as genetic health issues. We have to recognize what those are and how it impacts them and their health. We have to provide culturally appropriate care depending on what culture they're from. Epigenetics is kind of a big word. It's the study of how environment and behaviors impact genes. So we do have genetic things, and then we have environmental things that affect populations of people and how that all affects them together.